All right, well, good morning, everyone. I wanted to welcome you all to this year's annual Midwest Regional Virtual ASCO Review. This is our 23rd year of offering this comprehensive review of the latest updates and therapeutic advances in the treatment of malignancies. Just a few housekeeping items. With this format, I just wanted to go over a few things. So first, we are using Zoom. You can find all of your webinar controls by hovering over the lower section of the Zoom screen. You'll find your microphone and webcam and chat box options, among other things. Please make sure that your microphones are muted throughout the meeting. If you need to ask questions, please use the chat box or wait until the Q&A session to unmute yourself and ask your question. We'll address all questions at the end of each presentation. You can also use the chat function to send messages privately to individual attendees. If you have technical difficulties, please close your browser and use the link to access the webinar once more. Otherwise, feel free to send me a message via the chat box. The presentations are being recorded and will be uploaded to our event website at a later date. We do encourage the use of webcams if you're able to, just in order to help us have a more face-to-face atmosphere to the meeting. I also want to remind you to please use our virtual platform to visit our exhibitor booths. You can chat with company representatives live, so make sure that you take advantage of that opportunity and thank them for their participation. Without their support, the Nebraska Oncology Society would not be able to carry out its mission of enhancing patient care through oncology research, education, and healthcare legislation. We also encourage you to participate in today's scavenger hunt competition. Each exhibitor booth has a unique competition code located somewhere on their virtual booth. If you're able to find 8 of these unique codes and email them to me before the end of the day, you will be in the running for a $150 gift card. And continuing education credits are available for this event. Complete the evaluation on our event home to get your certificate. The link will be emailed to you next week. I'll now turn it over to Dr. Sue, our program chair for this event, and the Secretary Treasurer of the Nebraska Oncology Society.
I welcome everybody. Thanks for being with us. I have the pleasure of introducing our first speaker, Dr. Julie Brommer. She's going to give us our update on lung cancer. And welcome to Dr. Brommer to the Nebraska Oncology Society. Dr. Brommer is the director of the Thoracic Oncology Program and the co-program leader of the Cancer Immunology Program and professor of oncology at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. She directs the Kimmel Cancer Center on the Johns Hopkins Bayview campus and is co-principal investigator on Johns Hopkins's National Clinical Trials Network. She received her medical degree from the University of Nebraska Medical Center, College of Medicine in 1993, and completed her internship and residency in internal medicine at the University of Utah. And she later became chief medical resident before moving to Baltimore to complete her fellowship in medical oncology at the Kimmel Cancer Center at Johns Hopkins. She is an active clinical leader in the treatment of lung cancer and mesothelioma. She leads the organization of the Multidisciplinary Thoracic Malignancy Conference, whose members meet weekly to discuss thoracic malignancy cases that need multidisciplinary review and approach. Her research and clinical practice focus on the development of new therapies for the treatment and prevention of lung cancer and mesothelioma. Her research interests include early phase immunotherapy trials of anti-PD-1 antibodies, international phase 3 studies of immunotherapies in lung cancer, and investigator-initiated trials evaluating epigenetic therapies in combination with immunotherapies. Welcome, Dr. Brommer.
Well, good morning, everyone, and thanks for inviting me. I'm actually, as you said, a graduate of UNMC, but my undergrad was done at Creighton, and in fact, my son is there for his college summer preview, and we'll be starting there in the fall, so I'm super excited, but thank you very much. I am going to share my screen. Now, this year at ASCO, there wasn't a ton of new data for the treatment for lung cancer. But as I went through the program and watched the different presentations, I found a lot of things that were super exciting for me. So I hope that you find the same. So these are my disclosures. So we'll go through some new data for early stage non-small cell lung cancer. And as you know, there's a lot of changes. Not so much from this ASCO, certainly, but I incorporated some recent data from ESMO as well, showing new data for adjuvant therapy and then also neoadjuvant therapy. Locally advanced stage unresectable non-small cell lung cancer, we know that immunotherapy is standard of care, and I've incorporated one of the abstracts from more data from the Pacific study. And then for advanced disease, you know, things have really changed over the years, and it's certainly not the dismal treatment landscape of 100 years ago or 10 years ago. But certainly some data came out from pooled analyses that try to kind of helps us decide what to use. And then there was a lot of data about new drugs that are targeted therapies that will be coming out, I think, in the near future. So I wanted to give you a flavor of that. And then for immunotherapy for extensive stage small cell lung cancer, there was a study that was presented. Though it was negative, immunotherapy continues to remain the standard of care. So we'll review some of the top lung cancer abstracts from ASCO and incorporate this in update. So let's start with surgically resectable non-small cell lung cancer. So the Empower 110 study now has atezolizumab approved for use in the US for patients with resected stage 1B through 3A disease that is PD-L1 positive based on the Empower 110 study. Here, again, this was presented last year at ASCO, but for all patients, particularly those patients with stage 2 and through 3A disease, you can see here the hazard ratio for improved survival was 0.66 and statistically significant, specifically for those patients who had PD-L1 positive. Now at ESMO, a virtual meeting this past spring, the Keynote-091 study or Pearl study was presented, and there was some interesting updates at ASCO. Pembrolizumab was studied in patients with non-small cell that was resected, as you can see here, and patients were randomized to receive a year of pembrolizumab versus placebo after adjuvant therapy with chemotherapy. And you can see here the disease-free survival overall was significantly improved with a hazard ratio of 0.76. Interestingly, in a subset analysis, the patients with high PD-L1, you can see here, there was not any statistically difference between the two arms of adjuvant pembrolizumab versus placebo. You can see here, actually, the curves actually touch each other around a 2-year disease mark here. But interestingly, if you can see this area, the placebo arm actually did better. Interestingly, at ASCO, they looked at the different adjuvant chemotherapies that were used, and really there was no significant difference, though the paclitaxel and carboplatin arm actually crossed on the other side where placebo trended towards, or no treatment trended towards being better compared to the other arms. So kind of a comparison between the two adjuvant studies, the Empower 010, the control arm was best supportive care. The Pearls, it was placebo. The primary endpoint was disease-free survival of stage 2 through 3A and PD-L1 positive. And in the Pearl study, it was disease-free survival all the way from 1B through 3A. And both were very, very large studies and included a fair amount of across the board stage 1 through 3A. Certainly the Empower 010 had more 3A disease. And then PDL1 positive, the percentage was about the same. The studies were slightly different. It was required that patients receive adjuvant chemotherapy for the Empower 010, where chemotherapy was recommended in the Pearl study and carboplatin was permitted. So slightly different treatment, but I think the Pearl study was probably a bit more real world. But interesting, it had some confusing data, particularly in a patient population where we think that immunotherapy should really work the PDL1 high disease. And we'll see over time how overall survival shakes out. But the thinking is that the Pearl study may lead for approval for pembrolizumab in the adjuvant setting as well. So there's a lot of ongoing phase 3 studies actually in the neoadjuvant setting. I'll go over the Checkmate 816 study that was presented at AACR, and then there were some updates at ASCO. But this was a large phase 3 study that randomized patients to receive either just chemotherapy and various different regimens versus chemotherapy plus nivolumab. And the primary endpoint was both pathologic PCR complete response rate as well as event-free survival. There are other studies that are ongoing that we anxiously await the results, looking at immunotherapy plus chemotherapy in the neoadjuvant setting. Some of them do allow adjuvant therapy, but interestingly, the Checkmate 816 did not have adjuvant therapy. So this is the 816 study, again, taking patients with, again, this is the AJCC staging of the 7th edition. So it's a little old using this edition, but using large T tumors greater than 4 centimeters up to 3A and randomize them to nivolumab versus chemotherapy. Nivolumab plus chemotherapy versus chemotherapy. You can see here over a year ago, pathologic CR was significantly improved with the IO plus chemotherapy versus chemotherapy, but the event-free survival was also significantly improved. As you can see here, a hazard ratio of 0.63. So this has led to the approval of neoadjuvant nivolumab plus chemotherapy in the patients with resectable early stage disease. Interestingly, this improvement was regardless of PDL1 subtype, even PDL1 negative disease, as you can see here, had an improvement in survival. Of course, the patients with high PDL1 did seem to benefit even more greatly. And as you can see here, regardless of the use of either cisplatin or carboplatin, patients did seem to benefit. And as you can see here, interestingly, the carboplatin did seem to perform a bit better than cisplatin. Adverse events, there were 2 patients that had grade 5 surgery-related adverse events, and but deemed unrelated to nivolumab. One had a PE and one had an aortic rupture. But in general, the grades of toxicities were very similar across the chemotherapy versus immunotherapy plus chemotherapy. As you can see here, the treatment-related adverse events. One question that surgeons typically have and kind of shy away from is just that they're concerned about surgical related adverse events when you have someone that's undergone immunotherapy plus chemotherapy, that the surgery, quote unquote, is harder and may have more toxicities after surgery. And really, there were not that much difference between chemotherapy versus the IO plus chemotherapy. And at ASCO, Dr. Provencio presented the NADIM study. This is NADIM 2 that actually looked at using the 8th edition and specifically at stage 3A versus 3B disease that was felt to be resectable. In the past, at least in our group, we've always shied away from using neoadjuvant chemotherapy in patients with N2 disease. But now in this study, it included patients with N2 disease and actually even multi-station N2 disease. As you can see here, almost 40% of patients had multi-station N2 disease. These patients were randomized to paclitaxel carboplatin plus nivolumab versus chemotherapy only. And in this study, adjuvant nivolumab was allowed for 6 months versus observation. And the primary endpoint was pathologic complete response. As you can see here, even in patients with N2 disease or stage 3A disease, the chemotherapy plus IO significantly improved the pathologic complete response, as you can see. And the percentage of patients with complete response or partial response radiologically was also significantly improved. They also looked at predictive biomarkers, and they too saw that there was a chance for pathologic complete response even in patients with PD-L1 negative disease by initial biopsy. But as the PD-L1 positivity was increased, the chance of pathologic complete response did increase. So how does NADIM-2 add to Checkmate 816? I think that, again, it's taking a lot of real world disease, particularly stage 3A through 3B in the 8th edition that was felt to be resected. Obviously, this is a randomized phase 2, not a phase 3, and it specifically used carboplatin and paclitaxel. And there was a decent amount of squamous histology, though a little bit less compared to the Checkmate 816. But the pathologic complete response rate for stage 3 disease actually seems a bit better, though again, like I said, this is a randomized phase 2 study. But in general, we do think that patients with stage 3 disease do seem to benefit more greatly compared to, for sure, stage 1B disease with neoadjuvant immunotherapy plus chemotherapy if these patients are deemed resectable. So I don't know about you, but in our multidisciplinary conference or tumor conference, we always debate these patients with stage 3A disease, particularly multi-station disease. And our radiation oncologists always say, well, multi-station, you should just give them definitive chemotherapy and radiation therapy and use durvalumab after that. But with this data, at least in select patients that we feel are resectable, this is certainly a regimen that you could seriously consider in these patients. Obviously, we want longer follow-up in these patients and how they did, but we shall see. So I think the take-home messages is that neoadjuvant nivolumab plus histology-based platinum combination chemotherapy is one option for care of resectable stage 1B through 3A disease, including N2 disease. Patients with resectable stage 3 disease, PD-L1 level does seem to predict the likelihood of pathologic CR. And all these studies excluded patients with EGFR and ALK disease if it was known. And so we do think that molecular profiling is important in early stage disease. And there are studies that are looking at targeted therapies in the neoadjuvant setting as well. So what about a locally advanced non-small cell lung cancer? Now at ASCO, there wasn't a whole lot of significant data that was presented, but just to touch on a subset analysis that was presented in the Pacific trial. Remember, the Pacific trial took patients with unresectable disease and gave them concurrent chemotherapy and radiation, and then randomized them to durvalumab versus placebo. And really, this is greatly change the treatment regimen for these patients, because there is significant improvements in 5-year survival and improvements in progression-free survival in these patients. But the question was, how, in this study, it included patients with EGFR mutant disease, and a lot of the data that has come out has been small case series that have been published by various groups that showed that patients with EGFR mutant disease just don't seem to do well with durvalumab. And most of these patients do progress. And there is a concern about giving immunotherapy and then using osimertinib, just in the fact that there's a concern about increased rates of pneumonitis. So everyone looked and questioned about how did these patients do on the Pacific study. And Dr. Naidu presented this data looking at the EGFR subgroup this year at ASCO. And it did include patients on both arms. Again, these are very small numbers, but interesting data. And most of these patients, particularly those patients on placebo, did have prior chemotherapy. But as you can see here, just like those case series showed, patients with EGFR mutant disease just did not seem to benefit from durvalumab compared to placebo. And really, there was no significant difference between, in this subgroup, between the placebo versus durvalumab treated EGFR mutant population, as well as no difference in overall survival. So a lot of, we don't know what to do with these patients right now. There are several studies ongoing to look at targeted therapies after chemotherapy and radiation therapy. But in my practice, I tend not to give durvalumab in these patients because of the likelihood of them developing metastatic disease in the near future. But I do think more studies need to be done. How about for advanced stage disease? There was some data, but the biggest data, I think, in my mind, were some presentations for targeted therapy. For non-small cell lung cancer, particularly for patients who are never smokers, or patients with adenocarcinoma, checking for mutations is recommended, and there is a high likelihood, particularly in the adenocarcinoma patients, that you may find a targetable mutation. Now, we now have data and drugs for almost all of these, including, and I did not include the EGFR exon 20 patients, and now also for KRAS G12C patients. But there are newer targets coming out as well, which I'll go over. This study was the crystal study of adagrasib for KRAS G12C non-small cell lung cancer, presented by Dr. Spira, and had a New England Journal manuscript that accompanied this presentation. And we now have sotorasib to use in the second-line treatment setting for patients with KRAS G12C, but adagrasib is another inhibitor that is being studied and may be FDA approved soon. And in the crystal study, patients had overall response rate about 43% with a median duration of response of 8.5 months. The median PFS was 6.5 months, and the OS was approximately a year, almost 13 months. We are always interested in co-mutations. We know that KRAS can be co-mutated with STK11. These patients tend not to do quite as well with immunotherapy in the first-line treatment setting. Also, patients with co-mutations with KRAS KEAP1 mutations, again, these patients tend not to do well with immunotherapy in the first-line treatment setting. And so each study is looking at how do these patients actually do. The co-mutations with STK11 do not seem to affect the overall response rate in KRAS G12C inhibitors. As you can see here, the response rate is about similar to the whole patient population. in the 40% range. But the KEAP1 mutant patients don't seem to do quite as well, even with the tyrosine kinase inhibitors, with a response rate of not quite 30%. So how about a comparison between adagrasib versus sotorasib? And this, Dr. Pata went over this in her discussion. The patient populations were a little bit different, but the response rates were very similar across the two studies, the sotorasib being presented last year, but the disease control rate was very similar. The duration of response seems to be a little bit longer in code break that got a sotorasib approved, but similar PFS as well as overall survival with a little bit even longer follow-up. The toxicities are very similar. Any grade was slightly increased for adagrasib versus sotorasib. The grade 3 through 4 increased for adagrasib, where both drugs have a certain percentage of GI toxicities, as well as potential for QTc prolongation. Dose reduction or interruptions were really not that different between the two, though you can see here both interruptions and reductions was slightly decreased in the sotorasib code break versus the adagrasib crystal study. But those patients who discontinued was very similar between the two drug studies. Interestingly, the adagrasib CNS activity, there was evidence of CNS activity with the overall response rate in those patients with CNS disease, but the caveat here was that most patients had received prior radiation therapy before study entry. The sotorasib study excluded active untreated brain metastasis, but they did see also some CNS activity as well. Obviously, in these patients, I probably would not use adagrasib or sotorasib confidently in patients with active metastatic disease, and certainly would be using brain radiation for those patients with very larger tumors, not just a few millimeters. So what about patients with EGFR mutations? You know, you have osimertinib and then chemotherapy as standard treatment, but obviously we're all trying to figure out the different mechanisms of resistance that occur in these patients after osimertinib, and then trying to find targeted therapies. And so it's very frustrating in patients whose disease progresses and they're so used to being on oral therapy. It'd be great to be able to offer them a targeted therapy for their resistance. And we just don't have anything approved, but we're getting more and more data about combining different regimens based on mechanisms of resistance. One combination that was studied and presented this year was a Chrysalis 2 study. And in one subgroup looked at patients with EGFR TKI resistant disease and combining amivantamab, which is the EGFR MET antibody, plus lazertinib, which is a next generation EGFR tyrosine kinase inhibitor. And as you can see here, interesting, the response rate was approximately 33% with a duration of response of 9.6 months, with a clinical benefit rate of 57%. So this may be a possibility in the future for our patients after their disease progresses on osimertinib. There were certainly toxicities. If you've used the amivantamab in the clinic for patients with EGFR exon 20 insertion mutations, there are infusion reactions that can be seen. Some patients can develop pneumonitis, as in this study, and certainly rash can occur as well. But the safety profile was really what that was seen in this study was really similar to what was previously reported. So there's various different strategies that are emerging to overcome resistance, but none yet FDA approved. But even compared to the standard of care in the second line treatment setting, chemotherapy, these other either MET inhibitors or other ADCs, or even in some cases adding immunotherapy. I particularly use the Empower 150 data to use this in the second line treatment setting when I don't have a clinical trial for these patients. So what about using amivantamab, which is a MET antibody hooked to an EGFR antibody in MET exon 14 skipping mutations? Now, this study was presented looking at this drug in this particular patient population. And I don't know about you, but in my clinic, patients with MET exon 14 skipping mutations, they do have 2 tyrosine kinase inhibitors that we can use in the clinic. They do work well, but in my hands, I've run into problems with edema, significant edema that is hard to control in these patients. And so for a few patients, I've actually had to take them off the TKI. So when this data came out at ASCO this year, I'm pleasantly surprised and excited to see some activity of amivantamab in this patient population. And we'll see if this trial helps get this drug at least compendia listed as an option for these patients. And you can see they saw about a 33% response rate. Again, not quite as good as the MET TK targeted TKIs, but certainly activity. You can see here in patients with no prior MET inhibitor, the response rate is approximately 47%, and treatment naive patients, the response rate is up to almost 60%. The safety profile was very similar to other amivantamab treated patients, with the majority of the events being 1 and 2, and no new safety signals in this patient group. Again, like I said, you can see pneumonitis in amivantamab treated patients. But in general, the rate of discontinuation rate was only 5%. So what about for patients with EGFR exon 20, where amivantamab is approved for use? This was a phase 1/2 study that was presented of a new inhibitor, CLN-081. And in this study, it took patients, and this is an oral therapy. Again, this was a phase 1 study. And in patients with treated at 100 and 150, the response rate was in the 40% range. And the duration of response was quite long, particularly at the 100 milligrams. So they felt that the 100 milligram dose was the dose to take forward. The 150 milligram dose was pretty toxic, but at the less than 150 milligram, there was no grade 3 rashes or diarrhea observed, though treatment emergent pneumonitis was seen in about 4 patients, even at the 100 milligram dose. But you can see here, this is again, an early snapshot of this drug, with a median PFS about 12 months at the 100 milligram twice daily treatment. So potentially this might be a drug to watch for EGFR exon 20 insertion mutated tumors. You can see here we have mobocertinib, which is a TKI, as well as amivantamab, which is the EGFR MET bispecific antibody. And then if you look at the drug CLN-081, the response rate is very similar. Interestingly, the PFS and duration of response was similar, though the mobocertinib duration of response seems to be a bit longer. So maybe the CLN-081 will be another drug to watch for. And then just looking across the trials, again, obviously for our patients, convenience, oral daily therapy seems to be a bit easier to stomach, rather than having to come back to the clinic multiple times for the infusion for amivantamab. Certainly the response rates are very similar across the different studies, with very similar PFS rates across the studies. Certainly right now, mobocertinib and amivantamab it's approved for use, and we'll see if the CLN drug gets to that point. Obviously, for all of these drugs, the CNS activity is questioned, and obviously we need better drugs. So what about the rare of the rare? So it's like, why is Dr. Bremer presenting this since it's so rare? But I can tell you for a new fusion that has been discovered over the past 5 years, which is NRG1 fusion. So this is a very rare fusion in non-small cell lung cancer, and it is the NRG1 is a ligand for ERBB3 and ERBB4 receptors. And the incidence in lung cancer is pretty low, 0.2%. However, it just might make a difference for that 1 or 2 patients that you actually do find. And I can tell you, just recently in clinic, I had a patient who was a never smoker. Her disease progressed very quickly through immunotherapy and chemotherapy. And actually, she originally was diagnosed at the time of surgery. She underwent surgery for early stage disease, and her recurrence was quite quick. And again, her disease rapidly progressed through chemotherapy and radiation, chemotherapy and immunotherapy. And she came to see me, and her panel was quite small. It didn't include the panel that was used to look at for mutations and fusions was very small, and it didn't include RET. And so I pushed a bit hard. It's just like, oh, I just felt that there should be something in this mutation and fusion evaluation. So we did send it off to a company that had a broader panel and did find a NRG1 fusion. And we looked around, and actually on the report, it did recommend considering a clinical trial. And it was actually this trial, the Zeno, I'm just going to call it Zeno because I can't pronounce the whole name. But this drug is being developed for NRG1 fusion cancers. This is a bispecific antibody that blocks both HER2 and HER3. There's another drug also that was presented too, but you can see here the response rate across tumors. This is also seen in pancreas cancer. The response rate was 34%, and response rate was 35%. The median duration of response in this study, again, very small, but it was 9 months. With a 12-month duration of response was 27%. Interestingly, as you can see here, there were responses seen, but here, this is a global multi-center registry that Dr. Drillin of Memorial Sloan Kettering had published in 2021. And really, these patients do poorly with no matter what you give. And so the hope is that NRG1 fusion targeted therapies could potentially improve how these patients do. So I'll give you an update the next time that I talk with you, because I referred her to a clinical trial, and she's going to be starting this next week. So again, what about the other rare of the rare fusions? What about NTRK fusions? There were updates presented in the 2 trials, both in entrectinib as well as larotrectinib. These are targeted therapies for NTRK fusion positive patients. Again, very rare, less than 1%. But as you can see here, the response rate between these 2 drugs is between 60 and 80%. And here we have progression-free survival medians of 14 months with a duration of response between a year to over a year, and a median overall survival of 47 months in the larotrectinib treated patients, and not even reached in the entrectinib entrectinib study. Again, small patient numbers, but for those patients with NTRK fusion positive tumors, it can make a significant difference in their overall survival. So what about for patients without driver mutations? Certainly, we have various different options in the treatment armamentarium. We use PD-L1 as well as histology to help decide what to give them in the advanced stage setting. And for PD-L1 high disease, one option is single agent immunotherapy, which we've had data for a very long time that gives us significant improvements in 5-year survival compared to chemotherapy and a good response rate between 30 to 45% across the different studies of these 3 drugs that are now approved for use. We certainly have chemotherapy and immunotherapy, regardless of PD-L1 positivity, combining different PD-1 or PD-L1 antibodies with chemotherapy, but these approvals do not include patients with EGFR alterations, except for the Empower 150 data. But the nice thing is that chemotherapy and IO seems to be PD-L1 agnostic. So in the past, the FDA did do several pooled analyses, and this was a pool analysis looking at PD-L1 high disease across the different studies, and this was presented at ASCO this year. Last year, they looked at patients with PD-L1 positivity of 1 to 49%, and this year they presented the data for a PD-L1 high disease. Again, it included 6 trials of chemo IO versus chemo, and 6 trials of IO versus chemotherapy, including the IO-IO combination of nivolumab and ipilimumab. In the overall survival, there was no difference in the patient outcome, and the hazard ratio was 0.82. And for the progression-free survival, the hazard ratio was 0.69. That did favor chemotherapy and IO. And certainly the response rate also favored chemotherapy and IO in the PD-L1 high patient population. So they also did some subset analyses. The only patient group that seemed to benefit a bit more for PD-1 or PD-L1 antibodies by themselves was the patient group, the elderly patients of greater than 75 years. Otherwise, the different subgroups did seem to have no difference or favor chemotherapy and IO. And as you can see here, also there was a trend towards improvement with chemotherapy and IO in those patients who were never smokers. So the decision between single agent IO versus chemotherapy IO is really, in my clinic, is per patient. And we're not sure what the right sequence or combination, and there have not been any head-to-head studies. There is this Insignia study that is looking in patients PD-L1 positive and randomizing them to either pembrolizumab followed by chemotherapy or pembrolizumab follow at the time of progression, given pembrolizumab versus chemotherapy, or patients receiving pembrolizumab plus chemotherapy right up front. And this is ongoing, and certainly consider this. This is the Insignia, it's an NCTN study. So what about IO-IO combinations? Were there any new data at ASCO this year? Well, we did present 5-year survival data in the Checkmate 227 study. In the PD-L1 positive disease here, you can see there was a significant improvement in 5-year overall survival. As you can see here, it was 24% in patients with PD-L1 positive disease. In the PD-L1 negative disease, it was 19%. So again, very exciting data showing 5-year survival of an IO-IO combination without chemotherapy. We also looked at treatment-free intervals. So for all patients, they either stopped due to toxicity if they were benefiting, or stopped at 2 years. And there, of those patients who were 5-year survivors, 60% of those patients were treatment-free for over 3 years. So I think from a quality of life standpoint, this does have a significant advantage compared to chemotherapy. And we'll see in those patients who were treated with chemotherapy and immunotherapy, or even single agent, what it would be great to be able to see this type of data as well. Even in the smaller group of PD-L1 negative disease, of those patients who were alive at 5 years, there almost 65% of patients were treatment-free for over 3 years. We did look at quality of life, and the quality of life in those patients who were treated with nivolumab and ipilimumab were very similar to the overall patient population of the US, and actually was significantly improved compared to the chemotherapy treated group. Checkmate 9LA had a 3-year survival data update. You can see here, even at 3 years, there was an improvement in overall survival in the whole group, about 27%. So very similar to the Checkmate 227, yet this is at 3 years. If you looked at the PD-L1 native disease group, there was a 23% 3-year survival. And again, as you can see here, across the different subsets of PD-L1 positive disease, even in those patients with 1 to 49, the overall survival was significantly improved at 3 years, as well as in the PD-L1 positive disease. The hazard ratio was 0.75, not quite as good as the patients with PD-L1 1 to 49. So what about new novel combinations that were presented at ASCO? These may be coming, but still too early to know. There was one presentation presented by Dr. Philippe in the IO naive setting of FT alpha, which is a soluble LAG-3. This is a little bit different than relatlimab, the LAG-3 antibody that's approved for use for melanoma. This is actually FT does not bind to the LAG-3 on the T cell like the anti-LAG-3 antibody does. And so the hope is that this actually increases activated T cells and reduces the number of non-responders. So, and in this study, it combined the FT with pembrolizumab for several cycles, and then patients continued on single agent pembrolizumab. And the primary endpoint in this study was overall response rate. In general, they did not see any differences in toxicity. They did see some pneumonitis, but not any different than what you'd expect from pembrolizumab. And the same with other side effects here. The response rate, if you look at immune-related RECIST or even straightforward RECIST 1.1, was approximately 38%. And while the PD-L1 native disease group, there was a response rate of 28%, but probably a bit more tantalizing was those patients with PD-L1 high disease, the response rate was about 52%. And we'll see in larger studies whether or not this ends up being something to use in the clinic, but we do think LAG-3, at least the FT compound, does have activity with pembrolizumab in the IO naive setting. You can see here the 6-month PFS rate was 55%, and PFS did seem to be improved in patients with PD-L1 positive disease compared to PD-L1 negative disease. So the take-home message is that this is a novel mechanism of action, activity seen across PD-L1 subgroups, but the response rate in PD-L1 high disease, while similar to the agent of pembrolizumab, we'll see how this bears out in larger studies. How about for the second-line treatment in IO refractory? Is there anything to give besides docetaxel, and ramucirumab? This again was the study that led to docetaxel ramucirumab's approval based on the Lancet article and data that presented by Dr. Guerin. Remember, keep this in mind, the median overall survival of docetaxel ramucirumab was 10.5 months. And this is the lung map study. So Dr. Rechtkamp presented S1800A, which is a sub-study that was part of lung map. Lung map is an NCTN study. looking at patients either with biomarker-driven tumors or non-matched arms. And in this study, it takes patients who are IO refractory. And depending on either their biomarker, they are put into trials based on that versus non-matched sub-studies. And one sub-study that was open was S1800A. This study was a study that patients were randomized to pembrolizumab plus ramucirumab, which if you remember, it's an anti-VEGF antibody, or investigator's choice standard of care, which included docetaxel ramucirumab or single agent second line chemotherapies. The primary endpoint of this study was overall survival. So why ramucirumab? VEGF is felt to play a role in particularly Treg activity, and blocking this can decrease the Treg activity as well as various other immune effects. And the overall survival was significantly improved for those patients who received pembrolizumab versus ramucirumab versus standard of care. You can see here the median survival was 14.5 months versus 11.6 months. And one concern about the study was, well, maybe most of the patients didn't receive docetaxel plus ramucirumab, which is like, we feel the best of the best second line options. However, quite a few patients did receive, in fact, over 50% of patients received the standard of care. And actually in this phase 2 study, the median overall survival actually did trend to even better than the prior phase 3 study. So we do think this is a fair comparison, that the standard of care arm did perform potentially even better than standard of care based on the phase 3 study. But here again, the median overall survival for the pembrolizumab plus ramucirumab treated group was significantly improved. Interestingly, there was a trend towards improvement for those patients with squamous cell histology. You can see here this subgroup analysis showed that RAM plus Pembro was better than standard of care for those patients with squamous. And then also in the subgroup that actually received chemotherapy followed by IO and then went on the study. So we'll see how chemotherapy IO in the future. Based on this study, there are phase 3 studies planned. Toxicity was not significantly increased, but there were some grade 5 events both in both groups, but really not that much difference between the standard of care and the ramucirumab pembrolizumab, except for the increased toxicities that chemotherapy gives. So this could be a treatment option in IO refractory patients. It does offer some less toxicity than standard of care because you're excluding chemotherapy, but we do feel a phase 3 trial is warranted. Now, what about for small cell lung cancer? Unfortunately, this year, there wasn't that much for small cell lung cancer. The Skyscraper 2 study was presented. So anti-TIGIT antibodies, the tiragolumab is a anti-TIGIT antibody, which is a TIGIT checkpoint inhibitor. Adding that to atezolizumab plus chemotherapy. TIGIT seemed to have some activity in non-small cell lung cancer. So in this study, why not include it for small cell lung cancer? And so this study randomized patients with extensive stage small cell lung cancer to either the 4-drug regimen or standard chemotherapy plus atezolizumab. And unfortunately, adding anti-TIGIT to this regimen did not improve progression-free survival and did not improve even at the interim overall survival results. So the triplet of platinum plus etoposide and atezolizumab or durvalumab remains the standard of care for first-line treatment for extensive stage small cell lung cancer. And there's future studies to look out for adding different combinations of anti-TIGIT molecules in extensive stage disease, and even looking at IO plus lurbinectinib compared with atezolizumab single agent in patients with extensive stage small cell lung cancer. We'll see. There was a lot of data looking at smaller studies looking at subsets of small cell lung cancer that may help us hone down which patients actually should receive IO plus chemotherapy, but we shall see how this folds in the future. I wanted to include this study with a shout out to Dr. Ganti, who is at UNMC. He presented a comparison of quality of life between Q-day radiation versus BID radiation therapy for limited stage small cell lung cancer, which was a CALGB study. And in this study, and in studies in the past, BID from a performance standpoint was superior to Q-day radiation therapy when the radiation therapy went to 45 gray, and both arms were given with platinum etoposide. And this study was Dr. Teresi actually published this back in 1999, did show an improvement in overall survival with the BID radiation versus the Q-day, but the esophagitis levels were higher for those patients with BID radiation therapy. Now, in a different study, in this study, they looked at 70 gray Q-day, thinking that the higher Q-day may be superior to the 45 gray BID, but in this study, it did not show a superiority between the two in limited stage small cell lung cancer. And actually the overall survival was very similar, 30 versus 28 months. And from a toxicity assessment, there was no major differences in toxicity between the two arms. So this presentation looked at quality of life. And given the equivalence in efficacy, differences in quality of life scale may help us decide between BID and Q-day routes. And patients were administered the different quality of life scales, including FACDEL, during the radiation therapy and they were also asked to assess the treatment inconvenience at multiple time points. And if you look here, across these different scales, the FACDEL TOL mean worsening was less for Q-day radiation therapy at week 3, but more for Q-day radiation therapy at week 12. Esophagitis and difficulty swallowing was worse at week 3 for BID radiation compared to Q-day radiation therapy. So while the Q-day and BID regimens have similar efficacy outcomes, the Q-day radiation had a better quality of life score at week 3. The Q-day radiation therapy was perceived to be less convenient. The BID radiation had a better quality of life score at week 12. And so really the choice of radiation for our limited stage small cell will need to take into account logistical factors, how easy is it for your patient to get to radiation twice a day, and as well as the risk and duration of potential side effects and the impact on quality of life. Taking care of patients in Baltimore, if they live very close, it's easy to do BID radiation therapy. And I feel like I could get patients through all the radiation therapy a bit more easily, though they can have a more toxicity right up front compared to the Q-day radiation. But obviously, similar to Nebraska, coming in 100 miles and twice a day and trying to stay in Omaha is logistically a challenge compared to somebody that lives very close, as well as somebody who is trying to work through therapy. It would be very difficult to do BID radiation therapy. So it's really patient dependent. So in conclusion, ASCO did add some data, particularly more for early stage disease in the neoadjuvant setting for IO plus chemotherapy, but obviously adjuvant IO is for PD-L1 positive disease, is approved for use, and then for patients with EGFR mutated disease, osimertinib we know is approved based on last year's ASCO. Obviously, locally advanced non-small cell lung cancer consolidation IO is standard of care, but based on the subset analysis presented this year of the Pacific data in patients with EGFR mutant positive disease, small patient group studied, but there did not seem to be any difference between the durvalumab EGFR mutated tumor patients compared to placebo. And for advanced disease, while incurable, it's not a dismal treatment landscape. I do think that checking patients for mutations or fusions is very important and can lead to therapies that can be control their disease for a very long time. And based on ASCO this year, there may be also regimens, particularly for those patients who progress on osimertinib, may have for regimens for EGFR resistant disease as well. For extensive stage small cell lung cancer, really IO chemotherapy combinations remain standard of care, and we have yet to improve on that based on this skyscraper study. And certainly for limited stage small cell lung cancer, from a quality of life standpoint, there are differences in whether or not you decide to give BID radiation therapy for limited stage small cell lung cancer versus QD radiation. So, and I want to thank you again for allowing me to talk with you about some of the updates at ASCO. I hope this was helpful, and want to thank you from our whole team at Johns Hopkins. Thank you very much.
Thanks very much.
Oh, sorry, Dr. Singh.
No, thanks very much for such a great comprehensive update. We have time for questions.
Feel free to unmute yourselves or type those up in the chat box.
Yeah, I think that, interestingly at ASCO, there just wasn't a huge amount of data that is practice changing. I think the data that we had was more to either solidify what you do in the clinic or just give you more data to say, hey, the reason why I decide to use one regimen versus another, based on the pooled analysis or even for limited stage small cell. So there wasn't a whole lot of new practice changing groundbreaking data. I think the excitement remains in the neoadjuvant setting. But the question is, there's a whole lot of questions about who to select for that. Certainly it does require a lot of infrastructure in order to get a lot of data as you're trying to figure out how to treat these patients, and a lot of coordination between the different disciplines. But we hotly debate whether or not a patient should receive neoadjuvant chemotherapy in our tumor board on a weekly basis. So.
Yeah, that's you just addressed my question, which was how do we pick that neoadjuvant versus adjuvant for the resectable population?
Yeah, we've particularly for those patients with EGFR and ALK that were excluded from those studies, and that tend not to do well with immunotherapy. We struggle about how to get that answer quickly for a patient who we need to get on therapy or want to get on therapy. And so because it takes some time, we're trying to figure out ways to try to get that information more quickly, either a test where we can test for EGFR quickly and then just do IHC for ALK, or trying to figure out how to do that. And I don't know if anybody has any answers, I'll take them because we struggle. We're not using PD-L1 right now to tell a patient whether or not they should receive chemotherapy and immunotherapy up front. But certainly if patients go straight to surgery, we want to know that so we can decide whether or not to give them atezolizumab in the adjuvant setting. But I think the answer's still out there. What is better? I don't know if there'll be any studies to compare head-to-head neoadjuvant without receiving adjuvant IO versus just adjuvant IO. But it is a good question because, man, if you can just get treatment done with 3 cycles of chemo IO, have them undergo surgery and they don't need anything else versus making a patient have to come in for another year for therapy. I don't know about you, but I'd probably take that chance. So.
Any other questions?
I gave them all the answers, so.
All
Or it's
right.
too early in the morning and you need some more coffee.
All right. Well, with that, just thank you so much, Dr. Bramer. We really appreciate you coming.
You're welcome, and enjoy the day. I'm excited. You'll hear a lot of even cooler data coming out in the other diseases as well. So thank you.
Thank you so much, Dr. Brommer.